So tight to relax, that's where your shaking comes from. This is not a colonic. Do not present a patient having a colonic. That would not be a good presentation. Myoclonic, those are quick motor tics. That's different than rhythmic. So real fine motor tics. These are the ones that the kids after an epileptic seizure will have that are really sneaky and subtle. You'll see one big toe just tremoring. If a kid's coming with a seizure and you think you've broken them and you see any form of neurological output, they're still seizing. It may just be a variant of the one you just treated. So if you see myoclonic, those are the sneaky ones, an eyebrow that twitches, a right pinky that twitches, they're still seizing. And atonic, boom, that's when you hit the ground. Those are your drop seizures. Those are the patients you see walking around with helmets on 24/7. They have no idea where they're going to lose postural tone and drop. Please do not become a parent of the year. Wow. So everyone knows what a generalized seizure looks like. Convulsive behavior. These are really hard to fake when you have a real one. They're really easy to fake and be recognized as a pseudo seizure or a fake seizure if you don't know what a regular seizure looks like. You know what I'm talking about. The patient's flailing around their bed, their arms in big movements, and then they wake up and go, oh, what happened? That's not a generalized seizure. They didn't pee on themselves, they didn't bite themselves. You know exactly what I'm talking about. You've seen these patients, and those are psychosomatic. The generalized seizure, when you go to look for it, you can actually fracture and dislocate a shoulder if you seize hard enough from the myoclonic episodes. Most of the patients with real epilepsy will have a postictal state with generalized seizures, not with some other kinds. Your classic generalized seizure, you're dopey, you're confused, you're sonorous, you're combative patient, they can last up to 60 minutes, up to 4 hours actually, not just 90 minutes. So let's see if our video link is working. This is when you love YouTube, posting pictures of patients having seizures. More importantly, their children online. It makes my life easy because none of these are proprietary. So I can share them with you. So obviously, if he's in the hospital, he's got an EEG cap on. This is a teenager. And note he's using a coloring book, shows you his baseline status. But notice he stops. The right hand stops moving. The right head starts to turn, so he starts to localize. It
makes all kinds of
things. But it quickly becomes an organized seizure where the whole started spoken when he evolved into generating tonic-clonic seizures. If you've never seen a seizure, this is terrifying. Imagine this is your 5-year-old and you have no medical training. You would freak out. So kind of cut the parents some slack when they see this. It's absolutely terrifying. So obviously now we've got the tonic episode, arms locked out, rhythmic. And what do you see? This is your apneic episode. He's really not apneic. He's breathing. He just physically can't breathe because the diaphragm is spasming, right? He's starting to turn a little bit blue. This is where you say roll the patient on your side in case they vomit. They usually don't. They usually get blood in their mouth, though, right? And then they put them on oxygen. Usually the kids aren't going to have such a prolonged tonic episode that they can't get air in. If they do a prolonged episode more than 30 minutes, now you're getting a hypoxic phase of true brain injury because it's too hypoxic. You can see it's a little dusty at the top there. You can go from a tonic to a rhythmic to that. Someone want to guess how long that seizure lasted?
About 2 minutes, 40 seconds.
Yeah. The total time presented so far is 136. And the first 15 seconds was him coloring. So that's about a minute-long generalized seizure. The reason I bring that up is we're experienced. We've seen this before. Timing goes out the window, especially, again, we're talking, this is supposed to be a pediatric lecture. This is a kid seizing. Mom screams, runs around to find her phone, tries to call 911, yells for somebody else. The good news is for my groups here, Lexi and Fire, your average runtime is 8 minutes, 9 minutes to the nearest. So if you presume you're going to add at least a minute to 2 minutes to make the phone call, another 8 to 10 minutes to show up, you got a pretty good idea that the patient's been seizing in at least 10 minutes or less than 10 minutes. But to ask mom, how long's the all right, good. Woohoo. All right, clock movement. You basically get a transient loss of consciousness without loss of postural tone. Very, very common. The book actually says you have to 200 to 300 of these in a day. And if a teacher's not paying attention, this can be a classic reason why a school-age kid falls off the radar, goes from a straight-A student to failing because they're seizing 200 times a day during class. And all they end up having, now the ones I've chosen are actually a little bit longer. This one luckily highlights it for you. So hair flicking, eye fluttering,
Haley, what's up?
and a lot of swallowing is often what
Haley,
it
what's up?
is. Boom, she's right back to normal. That was about
Haley,
7 seconds.
What are you doing?
In the classroom can last 2 seconds. It's an eye flutter, a lip smack, and you're done. So they're that quick to be an absent seizure that if you don't know what you're looking for, you may not be able to recognize what they're actually having here. Same thing, this kid's just, not sure why the box is there, sorry. So he's using his brain, he's doing math, and watch his eyes first. See the eye fluttering, quick steering episode, a little bit of swallowing. Doesn't miss a beat. It's about 4 seconds. Rubs his eyes a little bit, but if you're not paying attention, you got 30 kids in your classroom, you're not going to pick that up in the back seat of the class. No postural tone, no tongue biting, no peeing on yourself, nothing. Quick phase out, and boom, right back to where you started. The problem is that 5 seconds is gone. They don't get that back. So if you have them back to back to back, they may think you're just sleeping in the back of the classroom rather than actually doing, whoops, that's not what I wanted. All right, so those are petite molar absent seizures. Another quality parent of the year. So some of the more subacute seizures, your partial or focal seizures. Complex partial, I say a simple partial is usually one extremity, classically the upper extremity. The patient is awake, they can talk. And some of the peds, we call them Rolandic seizures. So when you get these presentations, you're like, oh, they didn't seize, whatever. Yeah, if the kid's got one focal arm that was shaking for 5 minutes, just because they're not unconscious doesn't mean that they didn't have a seizure. Complex partial, same thing. They don't lose consciousness, but they are out to lunch. They're awake but disconnected. Think of a drunk 21-year-old coming home from the bars who falls and hits their head. They're dopey and confused and weird movements. That's what a complex partial kid looks like. And then they can evolve. Remember, you can always get more than one kind of seizure. It can evolve into a generalized seizure from a partial complex. All right? So your simple partial seizures can give you the aura. So if you have an old enough patient, ask any funny smells, any funny tastes in your mouth. They'll almost always, once they get good at this, they can tell you when they're having them right beforehand. It's like a migraine aura, same concept. But mentation is maintained. You occasionally can get frontal lobe involvement and eyeball involvement, but your partial focal seizures, and remember it's pediatrics, so it's just look at the left hand, that's it. Baby's awake, looking around, if you watch the eyes, there may be a deviate to the left a little bit, but that's it. And then what did you see get organized? First start with the left arm, now we see the left foot. So it's all unilateral, it's not hemiplegia or a stroke, but that's it, that's a partial seizure, or partial focal seizure, one side of the body only, wide awake. So again, you put that on a 18-year-old who's got full clothes on, those can be subtle, very subtle, and they still need active treatment. Good news is most partial focal seizures don't last that long. And oh, by the way, they do happen in dogs. Wide awake, shaking head, it's not a motor tick, it's a dog with a seizure disorder. That's a partial, it's a focal seizure. If you care, that's nature. That's supposed to be funny, guys, work with me.
You got to stand back. Okay.
So this is a good one because you can see the right arm's locked out. That's your tonic episode, right? Rigid arm, eyes deviate to the left, but then look what happens. He just starts flying around.
But he's definitely awake.
So this is a family, again, they're used to the late night TV episodes where they're seizing patient in the middle of the street, right? Listen to him talk. I don't know.
Okay.
Thank God we have iPhones. You can videotape this for me and go, yeah, that's a seizure. Because oftentimes we can't catch him, just like you can't catch a video has a lot of
It's okay. It's okay.
So look, he's breathing fine, he's not turning blue, he's just a right arm.
It's okay. It's okay. It's all right.
Of course, the kids listening
Now he's
old enough
like
to explain
twitching.
what's going on.
It's okay.
It's a partial focal seizure. All right, complex partial, you have impaired consciousness, you're amnestic to the event, It takes some components of the petit mal seizures, the lip smacking, the eye fluttering, the hair flicking, but you're not responsive. You can maintain some postural tone, but like I said, kind of like a puddle of mud, like a drunk person would be. Another parent of the year. I thought these were pretty entertaining. You see the child, right? So this is a kid already in the middle of a seizure. He's actively seizing right now. He's in the middle of Christmas. See the lip movement, the hand movement, the quick flutter of the eyes. So this is the partial complex. He's not responding to dad, staring in different directions. See the eye fluttering?
Do you know your name?
That's different than just a locked arm looking around, right? Whole body's involved. You're like, I don't know what happened. Exactly, because you're amnestic. This one is a little more obvious. So big kind of choreiform movements.
Okay.
Exactly what you see right now. See the eye fluttering again? Watch what happens right and left hand. Kids start picking. They start flicking their hair. They start swallowing. Start grabbing body parts. She has no idea what's going on right now. Doesn't it look like a drunk college student? So this is a complex partial seizure.
Cora, can you hear me?
Some of your post-ictal patients do this as
Say,
well.
Mom.
Usually they're not moving like this. The classic, see the lips are pursed, the eye fluttering, and we're drooling.
You okay?
And then you have partial focal seizures. So your myoclonic seizures, same thing. Remember myoclonic? So these are brief loss of consciousness where you get, okay, wrong one, sorry, buddy. This is my favorite thing. You have to listen. The siblings laughing at it, and the mom's going, oh, never seen this before.
It's not funny.
So you see the eyes close, and they start to lose tone, and then they snap right back to, and you get that myoclonic episode. Clearly different than the kid who just had the myoclonic, or the partial focal seizure with the tight arm on the right side. He is going out, coming back.
Chase, you right, buddy?
Say no. I love the other kid, just laughing at his brother. Where are we at? All right, and then you have the classic one. Actually, that one's not as easy to follow. This is just spontaneous loss of postural tone.
Okay?
There's no tremor, no shake, no eye fluttering, no nothing. Boom, your brain goes
have
out,
any more?
your whole body goes limp.
No.
He's gonna have another one? I'm like, yes, yes. These are the dangerous ones. You can break your neck if you're not paying attention. That's what all these kids were at home. These are really tough to break. So again, someone tells you what's happened. That doesn't mean they tripped on the curb, fell, and hit their head. Clearly, this is a non-empty if he's wearing the helmet, right? And this is my favorite parent video of all time. So he's wearing a helmet, so you already know he's got drop seizures or atonic seizures, right? So they just let this kid walk around the barn or the farm to try and get him on video. But let's fast forward to, remember, they lose postural tone, and down goes Johnny.
All right, man.
Wait, are you right, man? No, he's not all right. You're letting him walk around. But if they do, they come right back again and get full tone. 3, 2, there you go. He goes, ow. He goes, really nice.
Oh, jeez. Wow.
That's one was enough, you know.
Yeah, at that point you say, we're having a bad day. Let's just go sit on the couch, don't you think? So it was nice enough to share them with us of what drop seizures look like. So there's 7 different seizures I showed you. There'll be a quiz on them in about 5 minutes. So status epilepticus. So this criteria is quickly changing over time. They now are saying 20 minutes, and most neurologists feel the magic number is 15 minutes. The cutoff used to be 30 minutes. Continuous seizing or no recovery back to baseline between seizures is status epilepticus. I am fine when you come rolling in the ER to say, it's been 14 minutes and it's status epilepticus. That gets people's brains going to get ready for the next round of meds. Hopefully you'll have already given something. If I know a kid's coming in status or getting close to status, there's a different round of treatment. Usually if a patient seizes 5-10 minutes, it's not that we don't care, it's that usually benzos fix the problem. If they're coming up on the 15-minute mark and you've already given 2 rounds of meds, I'm up to bat to start pulling Keppra, phenobarb, fosphenytoin, something else, because we're heading down the pathway of poor oxygen to the brain. So by all means, hedge your bets. If you're getting close to the 15-minute mark, mind you, that's from the call to 911, not from the time you've seen them, or they seized 5 minutes, quiet for 2, started seizing again. If it's all part of the same episode and they have no purposeful response back to normal, that's status epilepticus. So you can overcall this, that it gets the ER person on the other side to get their meds rolling. I'll have pharmacies start pulling drugs based on weight from what you're telling me in the field, because the longer they seize, the poorer the outcome. All right? So the textbook still says 30 minutes, but neurology now feels it's 15 to 20 minutes. I'm cool. My opinion is 15 minutes is plenty. You saw the first video, right? 1 minute, 10 seconds. Imagine doing that for 15 minutes, what you're going to look like. Not good. So you got to remember, status epilepticus is caused by lots of things, right? Encephalopathy, sodium, hypocalcemia. What's the one thing y'all can check on the rig? Sugar. The easiest thing in the world that you can fix on the spot and have the kid looking like a rose by the time they get to me. Classic is blood sugar. I know sometimes you don't have time if you got a status seizing kid and you're worried about airway and all this other stuff. Really easy problem to identify, easy problem to fix. So what common feeding problem is caused by not so bright parents that leads to seizures from low glucose or low sodium? Any clue?
Diluting formula.
What is it?
Diluting formula.
Yes! Parents who are trying to save a little money, instead of doing 1 scoop of formula for 2 ounces of fluid, we'll do 1 scoop of formula for 4 ounces. So the babies get too much water, they'll get hypoglycemic, hyponatremic. Both of those things cause seizures. And we'll have kids roll in with sodiums of 112 and sugars of 20. And then we quickly go backwards and go, oh, you're a 3-month-old who's malnourished, underweight, and we just don't have the funding. The state of Kentucky is fabulous for kids that don't have resources. It is very easy to get a medical card for a child. Most of the parents that don't have one that need one just don't know how to get one. So UK will help them with that as well. Of course, bad things, CNS lesions, neoplasms, hydrocephalus. This is where a quick history is helpful. And of course, we have kids that drink things they shouldn't drink, so you can get poisoning as well. These things can lead to them. Obviously, age-dependent, neonatal seizures, when you see them, baby's been home for 2 days from the hospital and they're actively seizing, you're usually dealing with infectious etiology. You're not, or intracranial bleed or abuse. Very different than what you're going to see with your older kids. We're almost done. I know your brains are full. I'm trying to stay on schedule here. I do have one more thing that's relevant to show you that we really like you EMS people. So is anyone here involved in the Rampart study? Came out in 2012, 2010. So Rampart study is rapid anticonvulsant medication prior to arrival. And what we did is through the NET, Neurological Emergency Treatment Trials, and I was part of it, Dr. Humphreys, the neuro team, is ours was a primary hub of 18 hospitals. The EMS crews got these little boxes that had built-in timers, and if you came upon a patient that was actively seizing, and I don't remember the criteria, 5 minutes, your choice of randomization was either a dose of, let me get this right, IM Versed or IV Ativan. And we looked at the study in pre-hospital, and we didn't need consent because those are both standard of care treatments. So we weren't changing anything. All we were doing is looking at EMS, because some of my rural counties may only have Ativan, some have Versed. There's no standardization of what y'all carry. Usually any EMS crew has some kind of benzo on board. But then we all get excited of, we got to have an IV, we got to have an IV, we got to have an IV. Seizing 3-year-olds, not so easy to get an IV on, why they're shaking with a little vein and you're trying to give anticonvulsant medicine. So I'll read this for you. Punchline, IM midazolam was the same outcome and actually better outcome than IV Ativan. So I'm not sure mixing Ativan and Versed, frankly, personally, I could care less. I like to simplify that it doesn't matter what benzo you're getting. As far as I'm concerned, when you roll up on a scene, your dart should be in your hand, ready to stab the kid in the thigh with a dose of some kind of benzodiazepine. That will work as quick or quicker with less hospitalization than a kid that you're trying to get a line in and putzing around the back of a moving rig, trying to give a dose of IV Ativan and looking it up. So if you get a call, one of you are driving, one of you should be looking up the dose for an IM dose of whatever benzo you carry and have it at the ready. that's your best treatment option, and this study proves it. This was published in the New England Journal of Medicine, which is one of the top 2 journals in the world. So this was a big deal and a big study, and UK was part of it. It's very cool. So from your take home today, if you remember anything, look for the subtle seizures after the big seizures, because often they're still seizing. Look at the eyes. They'll often still be deviated, or those fine motor tic tremors. Continue treatment. Treatment is stop of seizures or stop of breathing. Keep the benzos going. Pick one. You got to stop the seizures to save the brain from hypoxia. And the second thing is give an IM dose of whatever benzo you want that's been proven to work better than an IV dose. Now, if the child has a PICC line, great, give it IV. But in the meantime, you can get an IV after you give the IM dose. And if they're still seizing after 3 to 5 minutes, now you can give your IV dose as well. All right? We will stop there to try and get us back on schedule. Questions? Lots of different kinds of seizures. Pay attention to the kid's eyes. Give an IM dose. And then call ahead and tell me the kid's in status, and we'll have drugs at the ready instead of just giving what you all have already given. Right?
Most protocols in the state, including the state protocol, says that we can't give any type of benzo unless they are in status, and they have clear definitions for that. So what you recommended is to not ignore that, but
so what is their definition of status?
Status is 3 to 5 minutes, seizure 3 to 5 minutes with no, with just postictal phase in between with no.
Well, I would agree with that, because by the time you get there, at least 5 minutes has passed. So if they're actively seizing when you roll up on scene, the first thing you should be doing is an IM dose of something.
Mm-hmm.
So it's not, I mean, unless you're in a park and you've got your kids and you're there with your own family.
Mm-hmm.
But any kid you see, and I'm okay with you not treating someone who's had a seizure and stopped. That's fine. The key is, though, is did they stop and then they're in the back of the rig and they start again? Well, now we're in status. And that's where people get confused is, well, the seizure stopped, waited 10 minutes, and they're back again. That's still all part of the same seizure cycle. They're still in status. Now you can give your drug.
So you think that we should change the definition of status and not even use that, or not, because in some of the protocols, it just says status epilepticus. And so if you're going off the definitions, it can be very confusing.
It is very confusing. I think you're looking at the neurology definition of 15 minutes versus the EMS protocol definition of 3 to 5 minutes. Most people feel you have a 5-minute window before you need to treat a known seizure patient. That's how long it usually takes for a parent to go find their diastat, roll the kid on their side, call 911, shove it up the rear, hit the plunger, and then wait and see what happens. They usually recommend let them seize for 5 minutes before giving drugs. These are experienced parents with known kids who have seizures, not first-time seizures. But by the time you roll up on scene for a seizure, easily 5 minutes has passed. If they're still seizing at all, give them a dose. So I agree, the terminology is different. Your status seizure is different than mine. Just know the definition is 15 minutes. By the time they roll into me, if they're still seizing, it's been 15 minutes. So it already meets my criteria for status epilepticus rather than, we'll call it lots of seizures for 5 minutes. I think you're right. The terminology is screwed up for you all. Or maybe it's screwed up on us. I don't know. Questions? Thank you for your time.